All right. Well, Dr. Zaenglein, thank you for joining us for the AARS Audiopearl. It's a pleasure to have you with us. And I'd like to ask some questions related to your area of expertise, acne in the pediatric population. So acne is usually thought of as occurring in adolescence, but childhood presentations can also occur. How do you classify acne in the younger age groups?
Well, the classifications typically used are grouped by the age of presentation. So typically we use neonatal acne, infantile acne, and prepubertal acne. Additionally, we've added, or some groups will add mid-childhood acne as a separate group.
Well, I know oftentimes it's a little point of confusion for dermatologists and others as well, but how do you differentiate neonatal acne from infantile acne?
So neonatal acne usually appears about the time the baby is due for its first pictures, much to the chagrin of the mom, usually around 1 to 2 months of age. It's characterized by those small erythematous papules that are scattered on the cheeks and the forehead. In this form of acne, comedones are not should not be present. Some groups who are not convinced that this entity represents a true form of acne have even advocated a change in the name, and they propose neonatal cephalic pustulosis. All of this confusion stems from the controversies in its pathogenesis. We know that there's increased sebum production due to enlarged sebaceous glands and due to the maternal influences in the neonatal period. There's high maternal sebum production. This may correlate with the increased newborn sebum production. This has been shown. And also both maternal and newborn androgens may stimulate sebum production. The role of malassezia is where, in neonatal acne is where the true controversy comes in. Several studies have found malassezia species in the pustules of neonatal acne, and these groups postulate a direct causative effect. However, all neonates with this disorder do not have positive cultures. And in one study, the numbers of malassezia were equal to those with babies with or without skin findings. So no matter what you call it, this common neonatal disorder likely will resolve over the course of a few months without any treatment. Infantile acne, on the other hand, I feel should almost universally be treated. This form typically appears about 3 to 6 months of age, but it can occur later, usually lasts about a year or two. Boys are definitely much more commonly affected than girls are, and there's often a family history of severe acne in these babies. There is common thought that having infantile acne will predispose you to more severe adolescent acne, although the data on that is not, may not be out there yet. The pathogenesis involves some of the factors related to neonatal acne, such as increased sebum production, but it also can be explained by the relative immaturity of the adrenal gland, which during that time frame can produce almost pubertal levels of DHEA. Boys can also produce elevated testicular androgens, and this also will contribute to that. Eventually, in most of these cases, the imbalances will correct themselves and the acne resolves. The lesions in infantile acne are going to look different, look more like classic acne than, let's say, neonatal acne. These you'll see comedones, both open and closed, and you're also going to see those inflammatory lesions that we see. Much more classic for what you think for adolescent acne. It does occur primarily on the cheeks and the chin, and not so much on the chest and back. Rarely you can even see nodules, and there has been many cases of severe nodular acne reported in infants. And the reason I advocate treating infantile acne is that in my experience, even relatively mild comedonal acne in these babies can lead to permanent scarring.
Yeah, I think it's very interesting. I actually, I'm curious about the data on whether the infantile acne, especially the more severe forms of infantile acne, whether that's related to an increased risk of severe acne later. And just from observation, I mean, one of my close friends from medical school, her child as an infant had relatively severe infantile acne, and lo and behold, years later, he's in my clinic on his way to college on isotretinoin. So I would be really curious to find out if that holds up and if others have noticed the same thing.
Yeah, I think it's hard to just keep track of those patients. So from 15, 20 years,
right.
So they're out there, and it's all. I think that's clinical dogma. But whether that data is out there, I haven't seen it.
It would be a long prospective study, I guess you could say.
Yeah.
Okay, so how about your recommendations on treating infantile acne?
The more or less the same concepts of treating acne that we use in adolescent patients are going to apply. You want to typically combine treatments to target the different mechanisms in the pathogenesis. Where the difference comes in is you have to pick products that are going to be appropriate for a baby. So most of the babies will get a retinoid because comedones often predominate in that form of acne. And so you want to stick to something fairly gentle. I typically use either a dappling gel or cream or a lower strength tretinoin, like 0.025% cream. Then I add in a benzoyl peroxide, 2.5% cream, or a combination product with benzoyl peroxide and clindamycin if they're able to tolerate it. Usually I will avoid washes in babies overall because they're squirmy at bath time and I don't want to get it in their eyes. In cases where there's a lot of inflammatory lesions, I add oral erythromycin. Remember, the tetracyclines are going to be contraindicated in children more or less under 8 or 9 years of age because of they haven't got their permanent dentition yet.
So I'm curious, I haven't heard much about the mid-childhood acne. So can you let me know, what is the concept regarding mid-childhood acne?
So neonatal acne and infantile acne and even prepubertal acne, those concepts have been around a while, but there's this group of kids that are in between. So these are children who develop acne between, let's say, ages about 1 to 2 up to about 6 to 7 years of age. And this is the age when they really shouldn't have acne, and it is by far the least common of the presentations of acne. This is a time when the child's androgens should be both relatively low and stable. Serum DHEAS levels are fairly high at birth, but these rapidly decrease over the first few months of life, and then they should remain quiescent until the onset of puberty. This usually occurs about 7 to 8 years for girls and a little bit later, say 8 to 9 for boys. Therefore, the children these children need to be seriously evaluated for hyperandrogen states.
And what kind of workup would you recommend for these kids?
Well, the differential diagnosis of excess androgen states is going to include premature adrenarche, precocious puberty, congenital adrenal hyperplasia, virilizing tumors, and Cushing's syndrome. So in addition to a complete physical exam that you need to look for physical signs of precocious puberty, you need to make sure also to look back at the baby's growth charts are important, and this is especially important when you compare it to bone age measurements. So bone age is important. It's often difficult to get an accurate reading for bone age, and it's important that you have an experienced technician if you get bone age for a child. The laboratory studies are going to include androgens, testosterone, DHEA, DHEAS, prolactin. You want to look at the LH, FSH, and then 17-hydroxyprogesterone and cortisol levels should be done. And if cases where you're suspicious, it may be easiest just to refer them to a pediatric endocrinologist to make sure that the evaluation is complete.
Okay. Now, what differences are there between acne in older adolescents and preteen children?
So acne can often be the first sign of puberty, and it results, again, from those increasing androgens, particularly the DHEAS is one of the first ones to rise. And also with that, they start developing seborrhea. Preteen acne is usually primarily closed comedones and a T-zone distribution, and these can be admixed with a variety of inflammatory papules and pustules. It's been shown that in girls that if you have early menarche and with early comedonal acne, you're actually more likely to have severe acne throughout your adolescence.
Now, when would you be concerned about precocious puberty?
So more or less the same concerns for androgen excess there are in mid-childhood acne will apply for prepubertal acne, but the incidence is going to be much less because these kids are going into puberty, so acne can be expected. But there are many cases of late onset, say 21-hydroxylase deficiency reported that can present with early acne. I think one of the main concerns in this age group is going to be polycystic ovary syndrome. Risk factors for polycystic ovarian syndrome have should be considered and evaluated in the children. These include early uncorrected androgen states such as congenital adrenal hyperplasia. Also, being small for gestational age may also lead to early adrenarche and may be related to the PCOS. So does having insulin resistance. So your kids that have acanthosis nigricans or obesity should be evaluated.
I wasn't aware about the children that are small for gestational age having early adrenarche. Is that something that we've learned recently about?
Fairly recently. It's in the endocrine literature. Not so much prevalent within the in the derm literature.
Oh, that's fine. Is it related to? Well, I guess it's hard to say what it would be related to.
It's hard to say what the relationship is.
Yeah, that's interesting. Yeah. Because you would think that a premature baby isn't going to necessarily go through adrenarche or puberty sooner, but that's sort of the opposite of what you would think. So that's interesting. I'd like to learn more about that. Now, how would you treat acne in preteens differently from adolescents?
Well, the treatments are essentially they're going to be the same, but compliance is your real issue in treating younger kids. I try to simplify and aim for a once-a-day routine by using combination products or products that can be used together in the same application. Many preteens have not, and also remember, like many preteens cannot swallow pills or they haven't had to yet, so that could be an issue if systemic treatments are required. They also were going to need some reminding by their parents until that routine is established. They may want their acne to go away, but they just don't have the maturity to adhere to that strict regimen yet.
Now, what about isotretinoin in the younger age group?
So it's uncommon to have to use isotretinoin in the preteen population, but it can occur. And remember that these kids are more likely to have their acne recur after a course of isotretinoin just because of their young age. It may be just that they're also the ones that are going to tend towards having more severe acne, but also they still have a lot of puberty ahead of them.
Yeah, I've noticed that a lot, especially the kids around age anywhere like 13, if they're on isotretinoin for the severe acne at that age, it's oftentimes that they're going to require a second course. And I always make it a point to let the patient and the parent know that because they hear from other people, well, isotretinoin, is going to cure your acne, that sort of thing. But I point out that because of their young age, that there is a chance that they may need to use it again. And I kind of let them know that up front just in case that happens.
Yeah, the expectations in a 12-year-old are going to be a lot different than a 17-year-old.
Right. Well, I'd like to thank you for your time, Dr. Zaenglein. I appreciate your input, and hopefully we'll all learn more about the ins and outs of